So my goal today is to give you some insight into what is this device that we talked to you about, and some of you are wearing, and you heard Tori mention earlier today. So what is the Optune device? And my goal is really to talk to you about how it works and why we think it works. And there's actually a number of different ways that we think it works, so I'm just going to talk about two of them for simplicity. So what is a cell? A cell is its own little compartment, and it's there's a boundary of the cell, and that's basically a fatty layer. And then there's internal components, and that's an aqueous or a water-based layer. And water, as many of you probably know, is a charged molecule, so it has sort of a plus side and a minus side. And tumor treating fields are electrical fields. It's it's an alternating current, which alternates in a couple different planes depending on where the arrays are placed on the head. And the idea is to subject cells to an electrical field that can exert a physical force on them. And there's a lot of cells in the brain, and you don't want to harm all of them. But it turns out that tumor cells, and especially dividing or growing tumor cells, have some unique vulnerabilities to an external electrical field. And so what I'm showing you here is a graphic of what it looks like when a tumor cell or any cell decides that it wants to become two cells or divide. So what you're seeing is those little bean-shaped things. If I can, there we go. This is not tracking. These things right here are halves of a chromosome. So this is DNA wound up really, really tightly. And typically there's it kind of look like this. So two of those put together. And so they line up in the center of the cell. And then these little strings are called microtubules, and they attach to them and sort of pull them off to the side. And the microtubules also have a plus side and a minus side. So, you could think of how these also might be affected by an external field. And the external field in this picture is represented by these lines around the cell. And I think the implication here is that, not every external field, for whatever reason, actually overcomes the barrier that is the fatty part that bounds the outside of the cell, the lipid bilayer. So only certain frequencies are able to affect the inside of the cell. And it turns out that that's a little bit cell shape dependent and size dependent. And so because tumor cells are funny, they don't look like normal cells, you can actually tune the desired effect to your cells of interest, in this case, tumor cells, leveraging the fact that they don't look like other cells. So I started to make this really complicated graphic and video, and Charles, I'm going to throw you under the bus. As you saw from that wonderful drawing in his last slide, we are just not very good at creating multimedia, so I decided to ask Novacure to do this for me. So let's see here. I have one video here to show you. Sorry. There we go.
Can you get full screen?
Yeah, I'm trying.
The green.
There is no.
In the far right. Yeah, keep going.
So you can try. It's actually not tracking. I'm just going to do this. If I unplug it, will it return it to this screen?
A little bit.
Oh. You get it? There we go. Thank you. Okay, great. So I'm going to go back. Okay. Okay, so here's a tumor. And what you're seeing is tumor cells dividing right there. And what you're seeing is they have unequal numbers of half chromosomes right there. And then what it's also telling you is that these tumor cells are not happy. They're stressed out cells. And when they get stressed out, they sort of bleb out like this and release their components. And these components can be picked up by these immune cells around here. And these are antigen-presenting cells. Here we're seeing that with tumor-treating fields, sorry, it's going a little fast. So tumor-treating fields are impacting these cells as they're dividing and causing some of them to die. And as they die, there's sort of two ways for cells to die. One of them is sort of organized and doesn't release a lot of particles that activate the immune system. And then there's sort of a less organized way of cells dying that does result in release of particles that are visible to the immune system and picked up by those antigen-presenting cells that you just saw. Okay, so I'll just skip this part. So this is an immune cell that's receiving important signals from this dying cell, and then it's receiving pieces of the dying cell, and it's going to take it in, and then it's going to traffic back to the immune organs, which it will be shown in a second. And those are the lymph nodes. In the lymph nodes, it will interact with other types of immune cells, and it will essentially train them, hey, this is the thing that I want you to go find, and I want you to go kill it. So here it is trafficking back to the lymph node. This is the immune organ. And it's going to train a whole big group of these little blue T cells, which are going to form the adaptive immune response. And then they're going to replicate, as you can see, and there's going to be a ton of them that will be produced by this lymph node. I will pause here. If you've ever had the flu and then felt on your neck, you have those painful bumps. Those are lymph nodes. Those lymph nodes are undergoing this exact process. So your immune system is feeding them parts of whatever virus or illness you have. They're entraining to that specific target, and then they're proliferating, and then they go back out to the body. And they're really good at finding that target. So they'll jump out of the blood vessels into, in this case, the tumor. They'll find the tumor, and then they will destroy the tumor. So this is really what we hope to achieve with immunotherapy. And the reason I'm bringing this up with tumor treating fields is because there are So when immune cells are attacking this tumor, a lot of times tumors will have little molecules that bind to and activate sort of a shutoff signal. And that shutoff signal is a way for the tumor to become invisible to the immune system. And so what you ideally would want is for the immune system to ignore that shutoff signal. And so we have antibodies that will bind to that shutoff signal and block it. So you have now an immune cell that can see the tumor. It will go to the tumor, it will attack it, and the tumor will try to shut it off. But when it tries to shut it off, you can give it another drug to block it. And so that's a type of immunotherapy. So I wanted to show that because it dovetails nicely from Dr. Cobb's talk, and it also is a clinical trial that we're running here currently, which we're very excited about. The more classic way that tumor treating fields work, going back to my talk here, is, so that was one mechanism, and then the more classic mechanism is, again, you have this electrical current that is physically pulling the charged components of the cell. And I showed you before that it causes the cell to die, and this releases all of those molecules that activate the immune system. But how does it cause the cell to die? So what you're seeing here is sort of a graphic of a cell that has its DNA lined up. And here are those microtubules that I showed you earlier. And so these are going to be now pulled off to both sides and segregated, like you see here, and then this little wall of charged molecules forms. So at multiple different levels, this structure is sensitive to an electrical current that might be pulling it this way and then this way or this way and then this way. So the microtubules, or these green little strings, are charged. The parts in the center are charged. And of course, the water essentially in the cell is charged. And so if this falls apart, if this whole structure falls apart the way that is shown here, because of these external electrical forces, this cell will die. Or even if it doesn't die, it will be injured and not normal. So what does that look like? Hopefully this video will work. So this is a picture of a normal cell. Oh, that's disappointing. Let's see. Okay. We'll not try to use videos in the future. All right, so a normal cell will just kind of pinch off down the center and divide and look like two happy cells. If a cell starts to experience a great amount of stress during that dividing process, it starts to bleb. So little bubbles kind of come off of the side of the cell, and the whole cell eventually will kind of devolve into just a bunch of little blebs or little bubbles. And those are little pieces of the cell. So the cell membrane around the cell sort of makes smaller spheres, and they contain smaller parts of the insides of the cell, and they just kind of get released. And then that will, trigger some sort of immune response that we can then try to amplify. Okay, there we go. Even if those cells survive, they don't look normal. And so what I'm showing you here is these are all tumor cells, but the panel on the right has been subjected to tumor treating fields. And what they're showing you is that you end up with more of these big unhappy cells. And I kind of took a little square here and blew it up for you so you can see it. So here's some weird looking unhappy cells. You can probably see that they don't look like these guys here. So not only do cells die, but also even the ones that don't die, a much higher percentage of them get injured and are not, successful tumor cells, which is our goal. So I think this video is not going to work also, so I'll just summarize. Great talk. Why do we do this? We do it because we have clinical trials that tell us it works. So thinking back to, I think, a conversation that many people in the room have unfortunately had, some of them with me, why do we do chemotherapy? Well, we do chemotherapy because in clinical trials of people that, some of them will get the drug, in this case Temodar, and some of them will get radiation. Adding Temodar to radiation results in an increased survival. People will quote sort of the median survival. I think 2-year survival is a much more interesting measure. So chemotherapy increases the likelihood of any GBM patient of being alive at 2 years by 2.5-fold, from about 10 to about 25%. That's why we do it. We know that those benefits are not equally distributed. There are some patients that benefit more. Tumor treating fields add to that. So there's a clinical trial where patients were asked to either do radiation, take chemotherapy, and then take chemotherapy by itself in part 2 of treatment, or do all of that, but in addition, wear tumor treating fields during the second phase of treatment. And those patients did noticeably better. So 2-year survival went from 26%, which nicely matches the other trial, to 37%. Or if you want to look at median survival, it actually added more time than chemotherapy did, probably because chemotherapy is, we think, mostly beneficial to a minority of patients. And then that last part that I showed you, that's sort of the where are we going? Can we think about other ways that tumor treating fields can be used, and can we try to augment those other mechanisms of action? So specifically, if we add drugs to boost the immune system or block the ability of the tumor to turn off the immune response around it, will that augment any immune component of the benefit from tumor treating fields? And so This is unconfirmed data, but this is why we're doing the trial we're doing. In a single smaller trial with no control arm, they had a 2-year survival of 52%. So these are incremental gains, but I think when you start from 10 and you end up at 52, it does add up. So this is where I hope we're going to be going. And since my videos didn't work, any questions about what I was trying to tell you? Yeah. Yeah. Yeah.
So, you have the leads and the grids and the strips that go on a certain orientation.
Yeah.
I'm assuming that when the cells are dividing, they're going to be kind of all oriented in different ways. Does it matter which way, like, strips go, or is it just making different currents that are disruptive in every direction?
So the question was, does it matter what orientation the arrays are on, and how that kind of fits with, the random orientation of dividing cells? I think it probably does matter. I think there's, and it probably also matters how the arrays are oriented in terms of what dose or how much tumor treating fields a specific location in the brain gets. I know that there is a movement to try to build sort of more customized array maps that will deliver a higher dose to the intended target where the tumor is. Orientation, I'm not sure. There's really only 2 positions for the current arrays. It's kind of like one's a little more forward, one's a little more back. But I think it's more about dose, and I think that that's actually something that is probably going to become part of treatment in the coming years. I know that it's being studied in Europe. So, yeah, David.
Well, I recall that immunotherapy is this giant wide open box.
Yeah.
All kinds of immunotherapy. Are there certain immunotherapies that are promising for glioblastoma?
Maybe. I think this is one. So there's a huge bucket of what is immunotherapy. So there's viruses that we can use to try to blow up, the tumor cells. There's viruses that we can use to try to entrain the immune system against the tumor cells. There's molecules like the one I showed you that try to make the tumor more visible to the immune system by blocking a sort of a shutoff mechanism. There's T cells that you can engineer. You can take from a patient and engineer them to target the thing that you want to target. So that's CAR T, right? So there's all these different approaches. Is one more perspective? I don't know. I think I would say the biggest responses I've seen in the literature have been to CAR T. There was a paper in the New England Journal, I think I've talked with some of the people in this room about it, where they had 3 patients and they engineered a really fancy type of CAR T. CAR just means it's a T cell receptor that's sort of fused to target the thing that you want to target, in this case, the tumor, and you sort of pick your favorite targets on the tumor. In that study, they had 3 tumors that shrank considerably, and the pictures were really impressive, but the effect was not sustained, and that's probably because the T cells didn't live long enough to sustain the effect. So that might be a problem with CAR Ts, that maybe you need repeated administration. I think the type of immunotherapy that's most advanced is, and I mean clinically advanced, like has been developed the furthest, is checkpoint inhibition. So those are the antibodies that I sort of presented but didn't name, which block the shutoff valve that the tumor has to try to turn off any immune system, any immune cell that's targeting it. So that's a pretty simple technology. It's an antibody that we make that targets the thing that we need to target. We know which proteins to target, and you infuse it into the patient once every 3 weeks. So that's actually what we're combining with Tumor Treating Fields in the trial that's running. Yeah. Other questions? Yeah, Brian.
The Betfid TTF, the 2-year survival rate there.
Yeah.
Is that isolated to people who were able to wear the device, the tumor treating field, for the entire time of their adjuvant?
It's the final data from the clinical trial, and there were people in the trial that couldn't quite meet that threshold. So it's just all comers who were on the trial.
Okay, so
And so probably, and there was subsequent data that maybe people that were at more did a little bit better. There was an option on the trial to continue wearing it after 6 months. So no, this is not the most cherry-picked population. This is the top line data for everyone.
so there's actually some hope for the 2-year survival, maybe beyond that, for people who work just for, like, you know, their first or first 2 cycles of adjuvant treatment.
Yeah, so you can imagine a patient that enrolled on the trial and for whatever reason was not able to continue wearing it, but they were still part of that trial and they would be part of that number. Yeah.
Thank you.
I think I saw another hand. Oh, Lida.
Do you think there's starting to be better, like, adoption of tumor treating fields, like more neuro-oncologists are embracing it?
I don't know. That's a controversial topic, and this is a recorded talk. So I think there is a lot of interest from patients. I think there's a lot of healthy debate in the neuro-oncology field. You know, I don't want to dismiss. I think there are reasons why there are skeptics out there. You know, they point to the lack of a sham device in the trial. There's some other criticisms, but I think more and more people are at least showing interest and want to have the information. I think most patients want to have a conversation about it. And I think most neuro-oncologists are at least presenting the information. So, yeah, Vanessa.
Like, when is it introduced? Like, I know, like, TTF is it always introduced after chemo and radiation, or has it ever been introduced sooner, like in conjunction with those treatments?
Yeah, we're waiting for that result. So there was a trial that was finished. UW had the trial open, and it has now fully accrued, and we're waiting for it to mature, which is we're waiting to find out what happened. And so they asked the question, what happens if you start the tumor treating fields during radiation? And there's a whole nother story that I couldn't get into because, again, my videos didn't work, which there may be some ways in which tumor treating fields actually help radiation to work. And so that was what that trial was trying to, that was the question it was trying to ask. But we don't know the answer yet. So in a year or two, I hope to be able to tell you. Anyone else? Mary?
So let's say you had a shunt. Would this work without affecting the shunt?
I believe shunts are a contraindication, so you cannot wear tumor treating fields with a shunt. Okay. We have one more talk. I don't want to take away from her time. Brenda is our wonderful social worker, and I'm going to out her that she is retiring, so she's leaving us. So I'm really glad that she's here to give this talk. We've been really blessed to have her here for 5 years now. And this time next year, she'll be on a beach somewhere. So hopefully for you.